Today we have our patient Isaiah. He's a 30-year-old avid marathon runner. 5 days ago, he was doing a bike ride bar hop excursion when he felt intense vertigo and imbalance come over him at the third stop. He began vomiting and was very ill, so he went to the ER, concerned he was having a stroke. Imaging came back negative, and the patient was prescribed meclizine for his symptoms. He reports being sick 2 weeks ago with COVID-19. We did screening, and his neck range was adequate for the testing that we were going to do. The arterial and ligamentous stability was all intact, and when he has the symptoms, he reports vertigo and balance all the time, especially when his eyes close or he's moving his head, and tests and measures are as follows. So we're going to do a Dix-Hallpike test, which is testing for BPPV, which is a type of vertigo. So first I'm going to show you how it goes. So if you want to hop off the table, I'll show you how the positioning and the action is going to be. I'm going to have you sit here with your legs up. I'm going to have you rotate your head 45 degrees, which is the position that we need your head in. And then you're going to hold my wrist as I bring you down into 30 degrees of extension, keeping the position. And we're going to look for vertigo symptoms, so if you feel dizzy, nausea, vomiting, and we'll put a trash can here in case you need it. And just let me know if you have any symptoms. I'm also going to look for the beating of your eyes, which is an involuntary movement called nystagmus. Okay? I'm going to have you go ahead and sit up. And I'm going to touch your left side first, since we're kind of suspecting that one's not as involved, so I'm going to have you face that way. And then I'm going to rotate your head pre-positioned this way. Go ahead and hold on to my wrist. And then I'm going to bring you down. Open your eyes. Do you feel any nausea, dizziness, anything spinning? Okay, good. And I don't see any nystagmus, so for the left side, you are negative. So we'll go ahead and repeat that measure again on your right side. So again, we're going to come here, repositioning. I'm going to bring it down. Go ahead, keep your eyes open. Any nausea, any vomit, anything spinning? Okay, good. So I keep you here for around 30 seconds just to check for any latent symptoms, but so far no nystagmus is seen. So I'm going to go ahead and sit you up. So the Dix-Hallpike test indicates that you're negative bilaterally for the BPPV. Okay, so that's good.
Okay, so Isaiah, next test we're gonna do something called like the head thrust test. So essentially all I'm gonna do is just gonna bend your head down just about like 30 degrees. And then all I'm gonna do is you're gonna fixate on my nose. So you're just gonna keep an eye on my nose, and I'm gonna grab your head and I'm just gonna kind of move it back and forth in a circle, okay? Then all of a sudden, I'm just gonna stop. I'm gonna do like a sudden stop. And all I want you to do throughout this entire time, just look through my nose, okay? So come right here. So come down 30 degrees, keep looking at my nose. Okay, so based on the test results, when I thrusted your head to the right, you seem to have no problem keeping your eyes on my nose. However, when I thrusted it to the left, I saw that your eye couldn't keep up and you had to like kind of refixate on my nose. So essentially what we call that is like a refixation of saccades. And that pretty much means this left side here is hypofunctioning compared to your right side.
All right, so the next test we're going to be doing is called the head shake nystagmus test. For this test, what I'm going to have you do is you're going to hold your head in this position, just slightly bent forward to 30 degrees. And then I'm going to have you close your eyes and you're going to shake your head to the beat of the metronome. And then after 20 cycles of that motion, you're going to open your eyes and I'm going to observe some of the motion in your eyes and see how your symptoms are, okay? All right, I'm going to go ahead and start the metronome. Go and close your eyes. And then when I start the metronome, I just want you to start shaking your head to the beat of the metronome for 20 cycles, all right? Ready? And go. And open your eyes. want you to follow my finger and bring it out here. And I'm gonna bring this up. Alright, and back. Alright, so how do your symptoms feel overall after that?
A little worse.
A little worse? Okay. So just from my observations, I saw that your eye moved quite a bit to the right, proving you have a right gaze nystagmus.
All right. So the next test we're going to be performing is a dynamic visual acuity test, and it's not to be confused with like being at the optometrist to see your vision. Basically, what we want to do is I want you from where you are. So this is a 6.5 feet chart, so you're about 6.5 feet away. So I just want you to read the lowest line that you can from where you are right now.
Okay. CRVSD.
All right. So that is at the 2063 line. And then what I want you to do next is that I'm going to set a metronome. And basically, I want you to shake your head to the beat of the metronome. And while you're shaking your head to the beat, I want you to try to read the lowest line that you can.
Okay.
So it's going to be a little harder. If you have any symptoms, there's a trash can right here for you.
Okay.
But just try your best. Try not to slow down as well. Okay. So if you could set the metronome to 120 beats per minute. All right. And go ahead and start shaking your head. And go ahead and read the lowest line that you can for me.
NVSOK. I don't feel really good.
Okay, here's the trash can. Go ahead and throw up. There you go. Okay, so now that the patient is stable and not throwing up anymore, I'm going to explain the findings. So, because you went 3 lines above from when you were just standing normally, that's still kind of within the normal range, which is losing 2 to 3 lines. But because you have symptoms, we're just going to kind of count that as positive because obviously you threw up, and so that tells us that there's something quite not working properly, and that you have a problem with gaze stability.
Okay.
All right, so the next test we're gonna do is just an ocular motor, testing your eye muscles. So I'm just gonna look at the position of your eyes. I'm just looking to see that they're both in the center and one isn't like moving off to the side. And yours look pretty good, so that would be negative. And the next test I'm going to do is testing the range of motion of your eyes. So I'm going to have you follow my pen, and I want you to keep your eyes on it the whole time. Okay? Good. So with that test, I'm just looking for your ability to follow the tip of my pen the whole time, and you did very good with that. So the next test I'm going to do is looking at the strength of your eye. So it's kind of similar to the last one. I just want you to focus on my pen, and without moving your head, follow my pen. Good. So your eyes were able to stay on point the whole time and hold the position, so that indicates you don't have any weakness. Alright, so the next test, I'm going to be looking at your ability to follow my pen back and forth. So we're just going to be doing side to side and up and down. Okay? Good. So with that test, I'm just looking to see if your eyes are making jumping movements instead of moving smoothly. And you were able to do it smoothly, so that test is negative. That's a good thing. And then the next test, I'm going to have my pen out here. And I want you, when I say pen, you're going to look at my pen. And when I say nose, you're going to look at my nose. Okay? So pen, nose, pen, nose, pen, nose, pen, nose. Good. So So that one, I'm just looking to see if you're able to keep on target. So if you're able to focus on the pen and focus on my nose without your eyes jumping, or if you're going too far, then you were able to do that. So we're gonna do the second part of that test. It's very similar to the one going across, but now we're gonna be going up and down. So when I say to look at my pen, you'll look at the pen. When I say to look at my nose, you'll look at my nose. Okay? So pen, nose, pen, nose, pen, nose. And same with that one. I didn't see you overshooting. You were able to focus on my nose, and you weren't making jumpy movements in between the tip of the pen and my nose. So for the last one in this series, I'm gonna have you look at my pen, and I'll show you first on myself. I'm gonna bring it in towards your nose, and I want you to tell me when the tip of the pen gets blurry, or you start to see like two pens. You start to see double. And then once you get to that point, I want you to say stop, and then I'm gonna measure from your nose to the tip of the pen and see how far it was. Okay?
Double.
So that is about 2 centimeters. So if it was greater than 5 centimeters, that would indicate that it was abnormal, and that would indicate that you had some other issues. But yours was 2 centimeters, so you are in normal limit, so we're good there.
Okay, so based on other tests that we did, we got a positive for direction fixed gaze evoked nystagmus, and it was always right beating, indicative of left hypofunction. And then he had a lot of spontaneous nystagmus, and it was right beating and worsened in the darkness. We also conducted outcome measures. FGA, he scored 27 out of 30. Modified sit-sit, he had loss of balance on eyes closed on foam. The DHI, he scored 65, and ABC was 85%.
All right, so our primary hypothesis is for vestibular neuritis, and we chose that for several reasons. One, because he recently had the COVID infection, and so we know vestibular neuritis frequently follows infections. He also has had a decrease of symptoms in the last 2 to 3 days, so that also points to vestibular neuritis. And as we did our test and measures, he was positive on, or he had symptoms and nystagmus on the gaze evoked nystagmus test. And then he also, throughout all of the testing, his nystagmus was direction specific. And we also know that vestibular neuritis can be confused with strokes. So our second hypothesis was a pica stroke, and we came up with that one due to the constantness of his symptoms, and possibly because he went into the ER, his imaging could have been early enough that it didn't show up as a stroke on the imaging, but we were able to rule that out with our testing. And then we also, for our third hypothesis, we're thinking maybe a bilateral partial vestibular problem due to the increased alcohol intake.